So this presentation is going to be about Chapter 9 in the Blossom textbook. It is going to focus on joint structures. As you know, joints are an essential part of the skeletal system. So really this is the second of two chapters over the skeletal system. Chapter 6 spoke about bone tissue in the skeletal system. We skipped over any lecture specifics on chapters 7 and 8, both of which did cover more specifics of the bones of the axial and appendicular regions. And now this chapter 9, we are going to be discussing the different classifications, types of joints. We'll describe a few movements that joints allow our skeleton to do, and then we'll finish up looking at a few specific joint with a few extra structures involved. And then I'll finish up this presentation with a small set of slides that are in addition to what is posted in the textbook. For this, we'll be covering all the chapter from 9.1 through 9.7. So joint structures. We know we've got 206 bones in the body, and every one of your bones, except the hyoid bone, remember that's called the floating bone, is connected to at least one other bone. And where two bones come together, that is considered an articulation. And articulations are joints. Sometimes these articulations are freely moving, sometimes they're minimally moving, sometimes there's little to no movement at all. And we'll be describing the different ways that these articulations occur, and hence understand the three different flavors of joint structures in your body. I will introduce each of these major types of joints in section 9.1, but then sections 9.2, 3, and 4 then go on and give just a little bit more detail about these. These first four sections are going to go rather quickly as I move through these sections describing these flavors of joints. So again, a joint is also called an articulation, simply where two bones come together. And we're going to see two different types of names for these different joints. There's going to be both a structural classification, and there's also going to be a functional classification. And I'll help you pair these together. There are a few nuances here that I'm not going to focus on too much. I'm going to go over the big story of this so that it's pretty easy to classify and understand which kind of joint belongs to each of these different classification categories. So let's start off with the structural classification of joints. Again, this has to do with the structures, literally as the name suggests, the structures that are helping to make up this joint. First, we're going to see fibrous joints. Fibrous joints are connected, as the name suggests, by fibrous connective tissue. And we'll see also in a moment that these are the joints where there's little to no movement. Then there are cartilaginous joints. And as the name suggests, there is a big piece of cartilage, sometimes hyaline cartilage, sometimes fibrocartilage, that is helping to link these two bones. And then finally, there are synovial joints. And by far the most common type of joint in your body are the synovial joints. These are where there is a lot of movement between the bones. This is where we'll find our synovial membranes. We'll find fluid filling up that space, and that is going to allow a significant amount of movement of your skeleton. Now, the other way of classifying the joints is by their functional classification. And again, let's look at these words and make sense of these. So we're going to have synarthrosis. A synarthrosis is an immovable joint, and this is going to highly correlate with the fibrous joints above. There is amphiarthrosis. These are slightly movable joints, and this is going to largely connect with the cartilaginous joints above. And then there are diarthrosis. These are the freely moving joints, and again, these are going to correlate and align with the synovial joints above. So just basically you have two different words to keep track of when you think about joints. The synarthrosis will be the fibrous joints, the amphiarthrosis will be the cartilaginous joints, and the diarthroses will be the synovial joints. So synarthrosis, as this animation will demonstrate to you, this is the connection that we see between, for example, the cranial bones. You would call these sutures. And so you've learned in lab a number of different sutures that hold the cranial bones together. And that is a great example of a synarthrosis. The coronal suture, for example, here is a great example of that. There's also another example in all of the different sutures, and you already know that you need to know the squamous suture, the lambdoid suture, the coronal suture, and don't forget about that sagittal suture that's not visible in this particular image. The amphiarthrosis, again, this is going to be limited mobility. The example that I want you to really hone in on for amphiarthrosis is the pubic symphysis. Recall, physis means growth. Sym or syn means to come together. And so this is where the pubic bones, right? The pubic bones come together, grow together. So this is a significant chunk of cartilage connecting these two bones. So this is an amphiarthrosis. There's a little bit of movement here. It's not as tightly held together as the fibrous joints. And this makes sense, especially in the female pelvis, as this cartilage actually softens as labor approaches and as birth approaches. And this gives the female pelvis more flexibility for childbirth. Another example of amphiarthrosis are the intervertebral discs. You know where these are. And you also know that that is a pad of fibrocartilage. And there is a little bit of movement between your vertebra. Okay, so we have two examples of amphiarthrosis. We have the pubic symphysis and we have the intervertebral discs. So these two vertebra, right, these two lumbar vertebra are able to move a little bit because of the cartilaginous joint seen here. Now, diarthrosis is or are all of the freely movable joints. The knee is a great example of that. And we'll see that the movement of synovial joints comes in a number of different categories and flavors. One way of categorizing this has to do with the number of different planes or axes on which the number of axes that the joint is movable. So we are going to see, uniaxial for movement in one plane, biaxial movement in two planes, you know bi means two, and multiaxial for three planes. All three planes are multiple planes. So the uniaxial joints, good example of those would be uniaxial. I want you thinking elbow and knee. Okay, elbow and knee. You know your elbow and knee normally only bend in one plane. Biaxial joints are going to move in two planes, and one good example of that are your metacarpophalangeal joints. Now go ahead and dissect that word for me if you would. Think about that word for a moment. You have the metacarpals. You know the metacarpals are the long bones in your palm and your hand, and the phalanges are your small digit bones. And so the connection between your metacarpal and your proximal phalanx or phalanges is your knuckle, right? What you would commonly call your knuckle. So the metacarpal phalangeal joints, aka your knuckle joints. Now, of course, in this course, I will not be giving out points for knuckle joints, hip joints, shoulder joints. We will need to learn the anatomical name for these joints. And then finally, there are the multiaxial joints. And some books might call them polyaxial or triaxial, but I'll be using the word multiaxial. And this is by far the majority of your diarthrotic joints. They're moving in many different axes. Take that back, not the majority. But the two main examples of the multiaxial joint are your shoulder and your hip joints. Okay, those are multiaxial joints. Because you can imagine your shoulder, man, you got lots of mobility as you rotate your shoulder around, as you move up and down, side to side, back to back. You have lots and lots of movement, multiple directions in your shoulder and hip. Let's just take a look at that, remind ourselves as we are beginning to get into labs 4 and 5, you are going to be focusing on not only the muscles of the axial and appendicular region, and you're not only going to remind yourself of all the bones in the axial and appendicular regions, but you're also going to be learning a significant number of bone markings. Bone markings, another way of saying those, pieces and parts, landmarks of bones. And so you will become very familiar with a number of bony markings. And as I go through this presentation, the images may or may not include all of them, but I am going to at least mention as many of these bony markings along the way. At first, this may seem overwhelming, or you might think that I'm kind of ahead of the game, and perhaps I am. When you first watch this presentation, you may not yet have been introduced to or be familiar with many of those bone markings, but when you do review this lecture before the exam, it'll be a really great way to be reminded of the bone markings that you have by then learned in lab. So here we can see this is the head of the femur that is up in this caved out area of the os coxa, referred to as the acetabulum. Remember from our vocabulary, acetabul means vinegar cup, strange word, but acetic acid is, vinegar is acetic acid. And so what you basically have here is a strange word that says vinegar, acetic, at the table, right? And apparently in Roman times, it was customary at a meal to have a little bowl of vinegar. I'm not clear if it was for cleansing or if it was more for food, flavoring. But regardless, it was customary to have a little vinegar cup at the table. And so someone imaginatively thought that if you take the hip bone, the os coxa, and you lay it on the table, that little cup that is formed by the acetabulum, or what is now called the acetabulum, sort of resembled that little vinegar cup. Weird way, but that's the ruling of that, or the derivation of that term. Now, here we have the femur, and this narrow region that I'm putting my pointer over, that's the neck of the femur. This large process here is the greater trochanter. Over here, this big opening in the os coxa, that is the obturator foramen. And if I could see just a little bit over where my pointer is now, that's where that pubic symphysis would be. So imagine now we're looking at a simplistic version of the hip, and you can see that the ball of the femur fits up into the socket, the acetabulum, and that creates lots of movement in multiple directions. So that's just a really, really quick introduction to this. I'm going to go now into the next couple of sections. Do review these questions to make sure you're feeling good about that. And let's just go back now and talk a little bit more about 9.2, fibrous joints. Fibrous joints. And recall, these are joints that have little to no movement. We introduced the sutures a moment ago. I'm going to give you a couple of more examples of this classification here in a moment. So this is where two bones come together and they have little to no movement. The gap between the bones may be extremely narrow. And there are three main flavors here. One, the suture. We know those. Those are the cranial bones coming together. And the connection between them is a fibrous connective tissue. Now, you know about ligaments as well. Ligaments are bone-to-bone connectors. You know they're made up of dense, regular connective tissue. And sometimes, so let's look at these three pictures as the examples. So on the left, in A, we have the sutures. Again, we have a dense fibrous connective tissue kind of gluing them together, little to no movement. If your cranial bones are wiggly, we got issues, right? Typically very tightly connected with little to no movement. Then something you've not seen in the lab because the bones are given to us in isolation, but here is the ulna and the radius, and you don't appreciate this from our models, but there is a interosseous membrane. We know inter means between, osseous bone. So between the bones, there is this membrane. This particular kind of connection is called a syndesmosis. And just appreciate that this is basically connecting ligamental, think ligamental, between the radius and the ulna. This is not meant to be a movable joint, but this is a structural connection between the radius and the ulna. And then the third example of a fibrous joint is between the tooth, any of your teeth, and the space found in either your maxilla or your mandible. You know, in the adult, we've got 32 teeth in a healthy, full adult mouth, 16 upper teeth, 16 lower teeth. And while teeth themselves are not thought to be bones, right? We don't add 16 more bones to our body and classify them as teeth. Essentially, a tooth is a bone-like structure, and it's sitting in the space. Now, that space that the tooth sits in is called the alveolus. And you're going to see that word alveolus a few times. I'm going to stick it up right down here and make sure that that word is included here. It may not be right here, but I'm going to just say the word alveolus. I'm just going to drop it right here. Because the alveolus is just a term for a space or a cavity, and that is the same term to use in the lung when we talk about the air sacs. So the small air sacs in the lung where gas exchange happens are also called the alveoli. So this gap is the alveolus, and the connection between the tooth and the bone is formed by a periodontal ligament. That makes sense. Peri, around, odonto, the tooth. So around the tooth, there's a ligament. A ligament connects a bone to a bone. And this special sort of connection between a bone and a tooth is referred to as a gomphosis. So gomphosis is the classification. It's held together by the periodontal ligament between the bone and the tooth itself. So all three of these are examples of fibrous joints. If you have a healthy dentition, your teeth are not wiggling. They have little to no movement. So gomphoses, the syndesmosis between some of our long bones, and the sutures are all great examples of fibrous joints. And you can read about those and see more of those classifications here. Now, in the lab, we also looked at the fontanelles. The fontanelles are simply the, quote, soft spots found in a fetal or in a newborn skull. In order for birth to occur, right, we need to have a squishy skull. And so these sutures are not fully formed yet, and there's more movement in a fontanelle than there is obviously in a suture. And so there are the posterior and the anterior fontanelles. You also in the lab are learning about the mastoid fontanelle and the sphenoidal fontanelle. Make sure you know those as well as the sutures. And again, syndesmoses, again, examples of interosseous membranes. This is found not only between the ulna and the radius, but we also see a similar structure between the tibia and the fibula. And then a lovely video animation on gomphosis as well, and a mention of that periodontal ligament. So that's it. Very quick, 3 examples of fibrous joints, make sure you know all three of those and the terminology that I use to describe those joints. Moving on to 9.3, cartilaginous joints. One of these I already mentioned briefly, and this is where we have a slightly movable joint, and the bones are held together either by hyaline cartilage or fibrocartilage. And we will take a look. Number one, the pubic symphysis. Already mentioned this one, right? Between the two pubis bones, there's a nice chunk of cartilage there. And then also, and you already are familiar with this as well, but we didn't consider it so much a joint, if you will, but you know, here's the femur. You know that not only is there hyaline cartilage that is on the articulating surface where that ball of the femur fits into the acetabulum would also have a layer of hyaline cartilage, but you know about the epiphyseal plate. And that epiphyseal plate or the growth plate is also hyaline cartilage, and it essentially, think about it, separates the proximal head and the epiphysis from the rest of the bone. So if you were to find a young person's femur, you would see that the head and the rest of the bone are disconnected because that growth plate literally connects, right? Acts as a slightly movable cartilaginous joint between those two pieces of the bone. Now, as an adult, these bones fuse together into one bone with a contiguous blood supply. But before that moment occurs, these are literally separated completely by that growth plate. So that is the epiphyseal plate. Watch that animation about that, and also the symphysis that we see as well. And that's a quick and very, very quick presentation on cartilaginous joints. Remember, cartilaginous joints are also referred to as those amphiarthrosis. And then finally, we get to the synovial joints. This is by far the biggest section when we think about classifying the joint structures. Most of the joints in your body are going to be synovial in some type. So let's take a look at a generic joint. This kind of looks like the knee, but this is not referring to the knee. This is just showing you where two bones come together. This is a generic joint structure of a synovial joint. And the point that I want you to see here is that you have two bones. You have two layers of articulating cartilage. You know that articular cartilage is, if we looked under the microscope, more specifically referred to as hyaline cartilage. But here's the difference. There is a fibrous membrane that is going to surround this joint space, along with the synovial membrane, the inner layer. And in here, there is going to be synovial fluid. This fluid is going to be a lubricant. It's going to allow the smooth movement of the two bones over each other. This fluid, though, is also the nutrient supply in large part for the hyaline cartilage. Remember, hyaline cartilage is made of chondrocytes living in lacunae, and these are living cells. So while cartilage is avascular and while cartilage doesn't replace itself, those cells do need to be fed during their lifespan. And so there is fluid. This fluid contains nutrients. And every time you walk, fluid is basically being kind of pushed under pressure into that hyaline cartilage. And this fluid is providing the nutrients necessary to sustain those chondrocytes. So this reminds me that movement of a joint is critical to maintain its health. If a joint is static and is not moving, then this fluid is not forced into the cells and the cartilage can begin to have a degradation or a breakdown. We'll talk about arthritis and different sorts of inflamed joints later on in this chapter. So, synovial joints have that capsule around it. It's fibrous connective tissue. And within that, again, we're going to have the articulating cartilage. We're going to have that synovial fluid in there as well. Many of your synovial joints are rather complex. We'll be looking at the knee, we'll be looking at the shoulder, we'll be looking at the elbow, we'll be looking at a couple of other joints as well. And what you'll see in all of them is that there are ligaments that hold the bones together to support those bones. There's also going to be a fair number of tendons connecting to around these joint structures, providing support as well. So remember, tendons are muscle to bone connectors. They are also made from dense, regular connector tissue. Now, there's a couple of additional structures that I want you to know that we find not in all, but in some synovial joints. Number one, a meniscus. Now, the meniscus is a unique form of cartilage. It is made of fibrocartilage, and where the example I'm going to talk about with articulating discs is going to be between the knee, the meniscus, or the two menisci. There are two big chunks of cartilage in the knee. One is the medial, one is the lateral meniscus, and we'll see those when we dive into the knee structures more specifically. There's also a chunk of articular disc in the temporomandibular joint. This is your chewing joint, as the name suggests, between your temporal bone and your mandible. We'll see more details about that here in a moment as well. We're also going to see bursa. A bursa is, bursa, plural, is a thin connective tissue sac that we find around a number of joints. And these bursae are going to provide basically a gel pack or protection from the tendons that are rubbing think about it, as two bones are articulating and are bending, the tendons and the ligaments are going to be rubbed upon, sort of like a rope going over a branch. And if you just pulled back and forth in that rope, you know that that can cause friction and that rope will eventually wear out. Well, we don't want our tendons and ligaments getting worn out or damaged as joints move. And so these bursa act as little gel packs, little protective sacs. And one can have bursitis, an inflammation of these sacs, which can lead to dysfunction in the joints. The nice thing about bursa is that they name themselves. So a submuscular bursa would be under the muscle, a subcutaneous bursa would be under the skin. We'll also see subtendinous bursa. These are going to be underneath tendons, again, to help protect the tendon structure. So here we're seeing for the first time the knee. And this is the joint that you're going to be learning the most about this semester. And we see that there are three bones in the proximity here. We have the femur, proximal. We have the distal tibia. Notice the fibula is not a part of this joint structure. And then associated, but not directly part of the knee, is the patella. And you'll see that the patella has its own cartilage and only articulates here with the femur. The patella does not directly articulate with the tibia. And then we see a number of ligaments. They're labeled. We'll learn about these. There's the anterior cruciate ligament, the posterior cruciate ligament. There's also ligaments. They're not labeled on this particular image, but ligaments that also connect laterally and medially to the knee. They're not on this particular diagram. This diagram is also showing us some bursa. Again, these bursa are here. There are these gray. In this picture, they're gray. But these bursa coming down here from the thigh, you have your quadriceps muscles. And your quadriceps femoris muscles come over the top of the kneecap, and they come down and they articulate, as you're going to be learning, onto the tibial tuberosity. And that tendon and ligamental structures would be prone to being torn and damaged if it weren't for these gel packs, these bursa that are protecting that tendon as it stretches and is rubbing against what would be rubbing against the bone is now rubbing against a softer gel pack of the bursa. And then also in this picture, we're seeing from the side here two chunks of cartilage. These two guys, although not labeled in this particular picture, these are the menisci. So these are the two extra pieces of fibrocartilage. They're very strong weight-bearing pieces of cartilage made of fibrocartilage. But notice that these menisci are in addition to the articulating cartilage that one sees on the articulating surfaces of the bones. And this is also showing us some of that synovial cavity, and there's going to be fluid in this space providing lubrication for all of these structures. So here's a little story about bursitis. Read through that. And when we get to types of synovial joints in lab, you're being asked to know just 3 of the 6 types of synovial joints. And again, here I will do the same thing. Of the 6, there are 6 types of synovial joints. I only want you to know pivot, hinge, and ball and socket. Okay, same list, the same 3 that were described in lab. Yes, we have condyloid. Yes, we have saddle, and yes, we have planar joints. But they're cool. They're important. But they're all found. Good representations of these 3 are all found in the hand and the feet. And I'm just not going to focus on those. So you need to know good examples of the pivot, the hinge, and the ball and socket joints. So let's get started. I'm only going to give you a couple of examples of each, so this will not be difficult to keep track of. So number 1, pivot joints. The first one I want you to know, actually the most important one that I want you to know of a pivot joint, is between C1 and your C2 vertebrae. You know C1 is also called the atlas, because it holds up the head, and C2 is the axis. And these 2 vertebrae are pivoting on each other. They're rotating. In fact, this is the joint that is responsible for your ability to turn your head to the left and right and to say no when you shake your head. So we'll see that again in a moment. There's also in the hip, in the coxal joint, that's a good example of a ball and socket. You've already seen that a little bit. So there's your multi-axial ball and socket joint. And then the last one I want you to know are the hinge joints. The elbow is a good example of that. The hinge joint is a uniaxial joint. It only moves in one orientation, only in one plane. So your elbow only moves in one plane as you bend and as you flex and extend your elbow. The other 3, again, I'm not going to focus on describing the saddle joints. I'm not going to describe the planar joints, and I'm not going to worry this semester about the condyloid joints. So pivot joint, here's a great little animation about it. Another pivot joint also occurs in your radius and ulnar in the elbow, but the one I want you to most really focus in on is that pivot joint between C1 and C2. I'm going to highlight that joint because this is a term I want you to know. Atlantoaxial joint. If you break that word down, you see the word atlas, C1, axial, C2. So between C1 and C2, that joint is a pivot joint, and it allows you to turn your head side to side. Hinge joints, nice little animation about this. Again, the one or the 2 that I want you to know are the elbow joint, and make sure also the knee joint. Those are the 2 that I want you to focus on that are hinge joints. We're going to skip over condyloid. We're going to skip over saddle. We're going to skip over plane. And we're going to end here at ball and socket. And your ball and socket joints are the joints with the greatest range of motion, right? They've got multi-axial movement in all 3 planes. And the 2 examples here that I want you to appreciate are the coxal joint, aka your hip joint, and the glenohumeral joint, your shoulder joint. Those are the two ball and socket joints in your body. Make sure you're using the anatomical names for these, the coxal joint and the glenohumeral joint. You know that the os coxa is the fancy name for the hip bone, and the glenohumeral joint is named because it's the glenoid cavity of the scapula coming in articulation with the head of the humerus. Glenohumeral shoulder joint. Make sure whenever on a test you're being asked to describe or name a joint that you are not using the kindergarten words hip and shoulder, but that you're using the anatomical correct terms. Now, this can go wrong, and I'll mention this again at the end in some supplemental slides, but if there's any sort of inflammation of a joint, that is referred to as some flavor of arthritis. Arthritis is not a single disease. There's over 100 different forms of arthritis. We'll describe just a couple of them in more detail later in this presentation. But arthritic changes happen from just good old aging, right? Aging, common, right? All of us will look forward to some sort of arthritic changes in our joint structures. That arthritis and that aging can lead to damage of the articulating cartilage. Recall, cartilage is an avascular tissue. It does not regenerate. So once that articular cartilage is worn down, it's gone. And now you have bone on bone movement, and that's very painful, hence the pain associated with arthritis. There are also a number of autoimmune diseases where the body literally breaks down and starts attacking the joint structures. And there's also, there can be infections that can lead to changes in the joint spaces. There can be bacterial or viral infections that get into that synovial fluid, and that can lead to very significant changes and arthritic changes in the joints as well. Now, the most common type of arthritis, and the one that all of us will look forward to, in fact, many of us probably already have a little bit of evidence of this type of arthritis in our body, even as a young person, and that is osteoarthritis, right? This is where the two bones are coming together, where there is an aging or a wearing and tearing of that articular cartilage. Again, most common. And what happens is that the smooth surface of the cartilage gets worn down. And remember, when we looked at how bones are formed, we didn't focus in on the very specifics, but you know that your bones differentiated from what was once a articulating or a hyaline cartilage in the primary and secondary ossification centers. And so when blood signals, when blood and oxygen are able to interact with hyaline cartilage, it actually causes the cartilage to become more brittle, more spurry, and this is going to reduce the smoothness of the cartilage. So with arthritic changes comes oftentimes a more bony appearance and a lessening of the smoothness of that hyaline cartilage. And here you can see, right, even the unaided eye, you can see that this joint space that I'm showing is not smooth anymore. You have bone on bone areas, and this is classic of osteoarthritis. When the cartilage is completely worn down and there's significant pain and dysfunction of a joint, you'll be visiting an orthopedic surgeon. Orthopedic surgeons specialize in bone and joint disorders, and oftentimes are specializing in knee, shoulder, and hip replacements and other joint replacements as well. There's some great animations and some great visuals in here to appreciate a total knee replacement or a shoulder replacement or a total hip replacement. Other forms of arthritis include rheumatoid arthritis. This is an autoimmune type of arthritis where The body begins to attack essentially the joint space. This sort of rheumatoid arthritis is more common in women because of the autoimmune basis of this condition. There's also gout. Gout is actually a metabolic disorder. There's a deposition of uric acid in the spaces, and this is usually more limited. This form of arthritis is more common in men, and more oftentimes it hits the big toe, hits the hallux, and so there's arthritic changes in the big toe. That is classically gout. Again, classically more common in men, and is thought to be partly related to diet. There's also genetic components to all of these as well. So again, any disease, over 100 different flavors of arthritis, any disease that causes a dysfunction and inflammation, a breakdown of a joint structure is a form or a flavor of arthritis. That brings us to the end of 9.4. I have a few more comments about arthritis at the end of the presentation when I jump over to the accompanying PowerPoint slides. In the book here, obviously, if the question's about saddle joints and we didn't talk about saddle joints, you don't need to worry about those particular questions. Plane and gliding is a joint. Again, we did not focus in on that. So if the question is asking about something that was skipped in the book, you clearly do not need to be responsible for that content. Now in lab, as we move into 9.5, you were asked to learn a number of different movements that our skeleton does. These movements are based upon the movement that our synovial joints allow us to do. So we have the ball and socket, we have the pivot joints, we have the hinge joints, and those joints allow our body to make some really cool movements. And so your job now is to understand and learn these different body movements. And we'll start off with flexion and extension. Remember, we always are thinking about the body starting in anatomic position before we start thinking about the movement from anatomic position. So this dude is in anatomic position at the beginning, and he is going to be moving his arms, flexing the knee. So flexion simply means a decrease in the angle. So we see the angle changing at the knee or the angle changing at the shoulder. And then extension is the opposite. So these all have the opposite words. Flexion, the opposite is extension. Now there's also hyperextension. And hyperextension, let's look at this particular view here. If the person in the black hair here is in normal anatomic position, as the person looks down, you are decreasing the angle at the neck. That is flexion. As you bring your head back, that is extension. And honestly, this is missing a word. When you look backwards, you're extending beyond normal 180 degrees. And so this term right here, where I'm circling, should really read hyperextension. You are looking up and you are hyperextending the neck, and that is excessive or extension beyond, right? Hyper, more extension, hyperextension. Abduction and adduction, using the arm as an example. Abduction, to move away, right? To abstain is to move away from something. And adduction, AD, you know from your vocab, means to come together. So duct is to draw. So to draw away, abduction. To draw toward, adduction. Circumduction would be the rotational movement. You can rotate your finger, right? You can take your finger, just stick your pointer finger out, and you can draw a circle. That is an example of circumduction. You can draw a big circle with your arm. That is circumduction at the shoulder. Rotation. We can definitely rotate the head We talked about that. That is that atlantoaxial joint at the C1, C2. But we also have lateral rotation and medial rotation at the hip. You can just be standing there and you can just rotate your foot outward and your whole movement is coming from the hip, or you can move the other way and move inward. That'd be medial rotation. Notice these all have, most of them have opposite terms, right? Lateral rotation, opposite medial rotation. Flexion, opposite extension. A few more, a little bit more specific ones. And we're only going to talk about this example of pronation and supination. Pronation and supination. So recall an anatomic position when your arms are down to your side and your palms are facing forward. You may not appreciate it, but the radius and the ulna are parallel in your antebrachial region. But when you flip your palms backwards, your ulna and your radius are crisscrossing over each other. So when you turn your palms backwards, that is pronation. And as you pronate, the radius rotates over or crisscrosses over the ulna. And then when you return your hands to anatomic position, that movement is supination, and the radius and the ulna are back to being parallel. In the ankle, we have an example of dorsiflexion versus plantar flexion. What makes this particular set of terms, I think, a little difficult is that they both have the term flexion in them. Dorsiflexion, if you're standing flat in the ground, that's the anatomic position. If you then pull your toes up, that is dorsiflexion. If you then point your toes down, that is plantar flexion. Think toe point for ballet. And dorsiflexion, you're lifting your toes up toward your knee. Inversion and eversion. Again, we're starting with anatomic position. And if you rotate at the ankle, sort of evert to go outward, invert to come inward. Retraction and protraction. If you're standing in anatomic position, sort of a neutral position for your neck and your head, if you were to pull your chin inward, that's retraction. If you were to then extrude your chin out, sort of like a chicken dance, and you stick your chin outward in an anterior way, that is protraction. So protraction, retraction, protraction, retraction. Also, this can be done with your mandible or it can be done with your shoulders. To elevate your shoulders would be to shrug up, and then if you were to bring your shoulders back to neutral, but then even depress them lower, that would be depression. We can certainly also demonstrate that with our mandible. In your hand, to pull your thumb and bring it across the palm of your hand, that is opposition. And when you put it back, that is reposition. So reposition isn't on this picture, but to pull it in is opposition. To bring it back to neutral is to reposition. And if you look in some biology books, it's a big deal that humans, we have, quote, an opposable thumb, because we can bring our thumb across our palm, and some greater apes or some lesser apes are not able to do that. So they don't have, quote, an opposable thumb. So that brings us through all of those movements. I would definitely highly recommend that you watch these very, very short animations to make sure you can appreciate these different movements. On exams or quizzes, I would have you, let's go back up, I would have you recognize these images. So I would ask you, is this arrow abduction or is this arrow adduction? Also on the exam, I might describe a movement in words, and you would have to pick which sort of movement was, what kind of joint movement was necessary for that body movement to occur. So definitely spend a few minutes just walking through these animations to make sure it all makes sense to you. Again, we have our movements of our joints. Again, I'm only focusing on pivot, hinge, and ball and socket. The other ones you can ignore. And then make sure that you look at these questions to clarify everything. Pretty amazing how our bones are able to move in so many amazing ways with the help of our joints. So let's take now a look in 9.6 at a number of synovial joints. Clearly, we're not looking at all of them, but we're going to look at some big ones. And there are a couple of joints I'm going to introduce here that we're not going to see in the lab in detail, but I want you to know these joints. Joints are pretty easy in that you are looking at two bones coming together. I want you to know the two bones that are involved in these joints. Oftentimes, the joint name, the anatomical name, like the glenohumeral joint, the shoulder, tells you what two things are coming together to make that joint structure. So focus in on that. As I go through these images of the synovial joints, I'll also point out important bone markings when they're obvious on the image. Let's start off. First one I've already introduced to you, and that is the atlantoaxial joint. This is between the atlas and the axis. And as we've already described, this is a perfect example of a pivot joint. What you don't appreciate in the lab is how this works. And so we're looking at C1, right? We're looking at the atlas. And the atlas, it's a cervical vertebra. So you, of course, see these transverse foramina. And what we see here are articulating facets of the atlas. And you know what bone markings sit on this resting pad. And you should now be thinking that's where the occipital condyles rest, right? That's where the two rounded bumps on the base of the skull, the occipital condyles, and they are going to articulate right here. This picture is also showing you this structure. This is the dens, also called the odontoid process. This is a bony projection from C2 down below. So C2 is not being shown here, but we are seeing the dens. And what you don't see in the lab is that there's a ligament that wraps around from both sides of the cervical vertebra of C1 and wraps around that dens. And so when you say no, it's basically your C1 and your C2 pivoting around your dens for that movement. Pretty cool. So this is the atlantoaxial joint. It is the primary example of a pivot joint that I want you to know. Temporomandibular joint. As the name tells us, it is between the temporal bone and the mandible. It is your main chewing joint. It is opening and closing your mouth. Now, this is a very complex joint in that in addition to chewing, think about it right now. If you're chewing some gum, yes, you can chew up and down, but you also know that you can go side to side, right? You can move your bottom jaw side to side and almost you can also stick your mandible out and pull it back. And so the TMJ is an extremely mobile joint. Lots of movement. And in addition to the regular articulating cartilage, there is another piece of articular disc in here that is going to be a part of this structure when we look at it a little bit more carefully. So here, this box, right, we're going to zoom in. And while I'm here though, let's go through over a couple of bone markings. So what is this opening right here? And you should be saying the external auditory meatus. This bump right here, this is part of the temporal bone. This is the mastoid process. You're learning that the sternocleidomastoid attaches to this. Here's our mandible. And there is the socket here. And you'll be naming those two processes in lab as well. We see here the zygomatic arch. The zygomatic arch is made up of two processes. There is the temporal process of the zygomatic bone, and there is the zygomatic process of the temporal bone, which together reach out and connect. You also know, while we're here, you know the word zygote. You know the zygote is a union of egg and sperm. Well, the zygomatic bone is basically the union between the facial bones, right? Your zygomatic bone is a facial bone, and the temporal bone, which is a cranial bone. So there's the union of the zygo portion of that term tells us it is coming together and uniting two different parts of our body. As we zoom in to the bone here, again, we've got really two joints in one space. So this is what makes this joint really complex and moves in so many different directions. And in the middle, there is that articular disc. So this is similar to the meniscus in that it's an extra structural part of cartilage that's found in this joint. The yellow spaces represent the fluid-filled spaces of the joint cavity. Again, there's that external auditory meatus here. So just know what bones are involved, the temporal bone meeting up with the mandible. The shoulder joint, what you will call the glenohumeral joint. Lovely animation here. Let's take a look at what we've got going on. We have the head of the humerus meeting up with the space of the scapula called the glenoid cavity, hence the name glenohumeral joint. There is a lovely joint space here with synovial fluid in it. So just know what two bones are involved. Now, how in the world does your humerus hang on to your scapula? Remember that this the scapula is part of your appendicular skeleton because it's helping to hold the arm on. And what we need to appreciate is that it's not just two bones coming together, but there's a whole host of ligaments and tendons from muscles that are helping to envelop your shoulder joint, your glenohumeral joint. And you'll be learning in lab about the rotator cuff muscles, the subscapularis, the supraspinatus, the infraspinatus, and the teres. So you'll be learning about those in the lab as well. So the teres minor, the infraspinatus, the supraspinatus, those three muscles are visible only on the posterior side. I think those muscle names are pretty easy when you start realizing what they're telling you. Supraspinatus is just telling you superior to the spine. Here is the spine of your scapula. So the muscle that sits above that is the supraspinatus, and the muscle that sits infra to the spine is the infraspinatus. And those muscles are sitting in a space, a fossa, an indented area. The supraspinatus is in the supraspinous fossa. The infraspinatus sits in the infraspinous fossa. So these words are going to start coming together. The vocabulary, the interactions of these structures will become more obvious as you begin to look at not only the muscles, but also the bone markings where they sit. While the muscle's not shown here, the subscapularis muscle sits here. This is the anterior view and sits in a space called the subscapular fossa. You also see that this is the biceps brachii. The biceps brachii comes up and attaches to two places. It's going to attach to the coracoid process, and it's also going to come up and attach to the supraglenoid tubercle of the glenoid cavity area. Again, those attachment spots, those origins will be covered in the Lab 5. So that may be a little premature now, but that will make more sense when you review this lecture before the exam. We see some bursa. They name themselves subacromial bursa, must be under the acromion process. Subscapular fossa or bursa must be also helping with the scapula, protecting all those tendons that are crisscrossing around the glenohumeral joint. Because the shoulder joint, the glenohumeral joint, is such a movable joint, remember it's a multi-axial joint, a ball and socket joint, that means that with more movement, it's even more prone to damage and to being injured in some way. And so there's a whole bunch of different types of activities and things that can hurt our shoulder movement. And one of those is frozen shoulder, or more anatomically referred to as adhesive capsulitis. Let's take a look at the elbow joint. Now this is it's actually a two joints coming together. It's a uniaxial hinge joint. It is the humeral ulnar joint. Okay. And it's also the humeral radial joint. So really there's two joints, but they are combined within the same synovial membrane. You do want to know the articulation spots. And so the humeral ulnar joint is specifically between the trochlea of the humerus and the trochlear notch of the ulna, whereas the humeral radial joint is the portion where we have the capitulum coming to the head of the radius. Clearly, there has to be a lot of ligamental structures and tendons that are holding these muscles, this very active joint, together. So let's take a look. So here is the humerus coming down. There's the trochlea of the humerus. It's going to articulate with the trochlear notch of the ulna. Bursa here. Bursa here. Right, the olecranon bursa makes sense. We know the tip of the elbow is called the olecranon, or the olecranal region. This bursa is going to protect the tendons coming down from the triceps. This is your triceps coming down, guys, right here. Triceps brachii coming down, comes around the ulna and attaches to the olecranon as its point of attachment. We can't see all of the attachments here because of all of these lovely ligaments that are holding this together. And so in the lab, there are some of these ligaments that you'll be learning. One is the annular ligament. It wraps around the head of the humerus. Annular, think annual. Every year the Earth goes around the sun in an annual way. It goes all the way around. So the annular ligament goes all the way around the head of the radius. You also are learning the two processes. So you have the coronoid process and the olecranal process. Let me show those to you where they're more obvious. Here we have the coronoid process. Here we have the olecranal process. Together they make the trochlear notch. The hip joint, what you will call the coxal joint, is also a multi-axial joint. That means it also is prone to a lot of damage and instability. It should make sense to you that the shoulder joint is even more movable than the hip joint. The hip joint, because we're walking on it, because it needs to be a little bit more, the head of the femur needs to go up deeper into the acetabulum. This joint is not going to be as movable as the shoulder, although it is extremely mobile and is the second example again of a ball and socket joint. A number of ligaments are holding this all together. The great thing about these ligaments, again, they name themselves. The iliofemoral joint must be going from the ilium to the femur. The pubofemoral is going from the pubis to the femur. The ischiofemoral ligament is going from the ischium to the femur. So these ligaments most oftentimes name themselves and are not a challenge. The ligament that's found at the head of the femur is literally called the ligament of the head of the femur. It is called the ligamentum teres, but you'll oftentimes just hear it called the ligament at the head of the femur. And you saw in lab that there is a little indentation in the head of the femur where the fovea, where this ligament attaches to the head itself. And so as we look at this, we are seeing a much deeper cavity. The acetabulum, there is the articulating cartilage. There's also the articulating cartilage of the head of the femur. There's an extra extension of the cartilage referred to as the labrum. You may have heard of someone tearing their labrum. And the labrum is a lip-like structure that helps to hold the head into its place. We also find a labrum in the glenoid cavity of the shoulder. You see the head of the femur coming up. You can even see in this drawing the artist kind of put in the greater trochanter, the lesser trochanter. They're sketching a little bit of the medullary cavity here. This would be red bone marrow, if we think about our long bone anatomy. So you are currently making some blood right here in the head of your femur. There's our pubic symphysis, a great example of a cartilaginous joint or an amphiarthrotic joint. This is the obturator foramen that we're glimpsing here. You're learning about the anterior inferior iliac spine in lab. There's a bone marking. And you're also learning about the three parts of the os coxa. The pubis and the ischium is the section that you are basically sitting on right now, your ischium. And we know that this is the attachment point for the hamstring muscles. Let's move to the knee joint. Now, the knee joint is the only joint that I don't have a fancy name for. It's just going to be the knee joint in this presentation and in your testing. And we're going to take a look at it because it's probably it's definitely the largest joint in your body. It's a little bit more complex. And there's a few ligaments in here that I really want you to know more particular. We'll talk about them in the lecture sections as well in the lab. But this is where we have those two significant pieces of fibrocartilage, the medial meniscus and the lateral meniscus. Again, those are fibrocartilaginous structures. And we have the coming together of the femur and the tibia. On the sides, there are two collateral ligaments. There is a lateral collateral ligament, and there's also a medial collateral ligament. You'll see these oftentimes called the fibular ligament and the tibial collateral ligaments as well. And then there are two ligaments deep inside the joint. One is the ACL, the anterior cruciate ligament, and the posterior cruciate ligament, PCL. Notice that in these terms, let me just highlight them. In these terms, tibio-collateral ligament and the fibular collateral ligament, we have a C term, right? For the fibular and the tibial collaterals, the C word is collateral. In the ACL and the PCL, the C word is cruciate. Cruciate is a term that means cross. So we're going to see that the anterior cruciate ligament crosses in front of the posterior cruciate ligament. That will help you remember that they crisscross. And lateral just means on the side. So the tibio-collateral ligament is on the side with the tibia, and the fibular collateral ligament is on the side with the fibula. Don't make this difficult. The names, everything names itself pretty straightforward. As we look down a superior view on the right of the knee joint, we're seeing those two chunks of cartilage. They are the menisci. Imagine the large condyles of the femur are sitting down into those large meniscal structures. Again, to tear the meniscus or to have the meniscus wear down, you've got bony on bone changes, and that's very, very painful and leads typically to a knee replacement. From a sagittal side, we can see the quadriceps femoris tendon coming down, wraps around in front of the patella. There's that bursa, comes down, another bursa, and attaches to the tibial tuberosity. That's a bone marking that you'll get to know really, really well. And we can see the lateral meniscus labeled. We can see the PCL and the ACL also labeled in this picture. From an anterior view, right, we know, you know, that there is the quadriceps femoris muscles coming down. And again, they come across the patella. Remember, the patella is considered a sesamoid bone because it is embedded in this tendon. So the patella is actually embedded in the tendon, and then it comes down and attaches to that tibiotuberosity. We see those collateral ligaments on the fibular side and on the tibial side. I should say too, while we're there, for more bone markings, let me go back up. The collateral ligaments are attaching to the epicondyles on the femur. So you'll see the epicondyles as well, labeled in the lab, and you can begin to appreciate that's where those collateral ligaments are attached up on the femur. The fact that I just said is also listed right here underneath this model image. Also, after watching this animation, make sure you know which ligament, the ACL or the PCL, is preventing hyperextension and which ligament is preventing hyperflexion. So watch that video if you don't already know the purpose of the ACL and the PCL. This is a great animation. It goes through the ACL and the PCL structures, discusses an ACL tear. Maybe some of you in the room have damaged your ACL or PCL. Like all ligamental injuries, surgery is required typically if there's a significant injury, and repair is slow and laborious because, as you all remember, ligaments are made of dense, regular connective tissue, and because they are almost avascular, not completely, but almost avascular, they are very, very slow to repair. And recall, what is being stretched or torn are a bunch of collagen fibers. And so once those are torn or damaged, they are not likely to ever be back exactly the way they were even after surgery. Here we can see the meniscus, and you can see there's a breakdown of the meniscus. This would be leading to a torn meniscus or arthritic changes as well. Great animations through here. If you've ever had any sort of knee injury or know somebody who has, I think you would really enjoy learning more about it. And I will not be asking you about any surgical procedures, but I definitely want you to know what the ACL and the PCL is or are doing and what the menisci are doing in the knee joint. Moving down to the ankle joint. This one has probably the most unusual name, or at least the least familiar name of all the joint names. You won't hear this as often, but the ankle is also called the talocrural joint. Recall the talus is the most proximal, the most proximal of the tarsal bones, and the tibia sits down on the talus, and the crural, recall, refers to the front side, the anterior side of the tibial region. So we take a look, we can see the tibia coming down. Can't see it in this view, but it's sitting right on top of the talus. The fibula is coming down on the other side. Look at all those amazing ligaments holding everything together. We can see it more clearly here. This is more from a lateral view, and we can see the fibula coming down and attaches. Now the fibula comes down and attaches, and this extension right here is called the lateral malleolus. And on the other side, the tibia comes down the other side of the talus and forms that medial malleolus. Again, look at all these amazing ligaments that are holding all of those 7 tarsal bones together. So you have the tarsal bones all connected one to another. You have the tarsals connected to the phalanges. You have the phalanges, or so the metatarsals. You have the metatarsals attached to each other as well. And that doesn't even begin to include the ligaments that would be found here. You also have a very significant ligament underneath your foot. Plantar fasciitis is when that ligament gets upset and causes pain with walking. So again, a quick review of those joints. What I am focusing on is make sure you know the anatomical name of those joints. Make sure you know if those joints are uniaxial or ball and socket. Make sure you know the bones that are involved with those joints. Make sure you know the main structures like the meniscus or the bursa. Not to name them specifically, but just recognize that there are bursae and the menisci in some of those joints. To recognize also if they are, I think I already said this, if they're multi-axial or uniaxial. Answer those questions, and then there's just a couple paragraphs here about where do joints come from. Recall, your joints are formed during embryological development. They are being formed in conjunction with your bones, and the embryological tissue that gives rise to all your bones, your cartilage, your connective tissues, recall, is the mesenchyme. And the mesenchyme is, even before that, derived from that mesoderm, right, the middle layer of the early embryo. We will see in a moment, and we've already seen in the information for exam 1 about how limbs grow. And you know that starting around the 6th week, we saw that picture of apoptosis between the 5th and the 10th week of human development. Around the 6th week, the limb starts to elongate, and we start to see the hyaline cartilage being formed as that limb is extended. And then you know that from there, we go through endochondral ossification to convert that cartilaginous model into bone. By the 12th week of embryological development, we've got this process pretty much done. And at birth, you know that many of the bones have certainly not reached adult height, length, that we still have hyaline cartilage in the epiphyseal plate. We continue to elongate the bones through that endochondral ossification process, and that sometimes at adolescence into early adulthood, that epiphyseal plate becomes the epiphyseal line, and the hyaline cartilage of the growth plate is lost, but that in healthy bones, the hyaline cartilage at the articular surfaces is maintained as part of that synovial joint. So that's just a couple paragraphs on where and how joints were developed and connects to things you already appreciate. Okay, now that we have finished the chapter in Blossom on joints, I'm going to jump over to a few supplemental slides that are posted in your Blackboard site and walk you through these slides as well. Not very many. We're going to talk about arthritis a little bit more, but let's also discuss something that I've mentioned a couple of times along the way, and that is the more mobile a joint is, the less stable it is, right? Or say the other way around, the more stable a joint is, think your sutures, the less mobile it is. So there's an inverse relationship between mobility and stability. So the glenohumeral joint is an incredibly mobile joint, multi-axial, amazing things we do at our shoulder, but that also means that with that great movement, we have less stability. And so the shoulder joint is the bread and butter of an orthopedic surgeon, right? Of a physical therapist. People are hurting their shoulder all the time because the gift of mobility brings with it the curse of a lack of stability. Right after that, think about the coxal joint, right? It's also multi-axial, lots of movement, not quite as mobile as the shoulder, a little bit more stable than the shoulder, but still sits over here on the left-hand side of this. Lots of issues with hip injuries. In the middle somewhere, you might consider the elbow joint, right? We have a uniaxial hinge joint. It is quite mobile, It is quite stable, although, right, we again can have issues with elbow. It's not perfect. And then as we get into the intervertebral discs, remember this is an example of a cartilaginous joint, amphiarthrosis, a little bit of movement, rather stable, right? Very stable joint overall. And then finally, the least movable at all are the sutures, your fibrous joints, and that less mobility means that these joints are incredibly stable. So just appreciate that continuum. So you have probably heard of the term osteoporosis. The term breaks down osis, a abnormal condition of or a condition of. Pore, where the bones are more porous or they lose their density, and osteo, bone. Now, this is a diagram. It's a little bit misleading, but we're looking at spongy bone here. We've not looked at spongy bone under the microscope. I'm not asking you to recognize this. I just want you to see that in spongy bone, it kind of looks like a sponge, lots of little porous spaces in here. And notice that the magnification here is 20. And if we zoom in a little bit closer, now we're looking at spongy bone with osteoporosis, and you can see in this higher magnification all these little spots, all these little porous marks. Looks like a bunch of little pores, right? So the bone has become more porous. It's become less strong. It's become more brittle and more prone to breakage. Now, there's a number of medications that people can take if they have osteoporosis, and they are a class of drugs called the biphosphonates. What I want you to appreciate, thinking back to our skeletal system, is that biphosphonates as a group of medications interfere with osteoclasts. Well, you know that osteoclasts are the cells that break down bone. And so by taking biphosphonates, a person is interfering with their osteoclasts, and that is going to hopefully slow down the disease process of osteoporosis. Arthritis, mentioned it earlier, mentioned that arthritis is a whole group of diseases, all of which in somehow inflame or cause a breakdown, some sort of degenerative process of a joint space. And as we look at these x-rays on the bottom right, here is the knee, and you can see that there are places where you can see bone on bone. You can see the femur coming down, and you can see there's a direct connection down to the tibia. That should not be, right? The menisci and the hyaline cartilage should be maintaining a lovely space there full of fluid. And here we see radiographic evidence of arthritic changes. In the top, we can see a largely disfigured joint structures of the hand. And in this lower picture, look at this. This is a very significant case of rheumatoid arthritis, and you can see where the joints are no longer even lined up. There's so much inflammation and dysfunction of the joints that the bones are not even lined up, and these are very, very painful forms of arthritis. Here's another one, right? So we're looking at the person's hand. Here's that person's x-ray. Look at this, right? I mean, no wonder it's very painful. There's total loss of the joint structure. The bones are no longer articulating in any normal way. So very, very painful. Again, rheumatoid arthritis. Rheumatoid arthritis is not uncommon, but not as common as osteoarthritis. And rheumatoid arthritis is a form of autoimmune arthritic changes. So let's just talk a little bit more about arthritis. It is a very prevalent chronic health problem. We have over 53 million people in the US currently, the last numbers I've seen, with a projected incidence of 78 million people by the year 2040. About 1 in 5 people in the US has some form of diagnosed arthritis. It is a leading cause of disability for people of all ages and is second only to heart disease as a cause for work disability. It affects everyday life activities, causes millions of visits every year, lots of hospitalizations, and has a huge impact on the US economy when we think about the loss of work and income. Again, arthritis is not just a type of disease of the elderly. There are forms of arthritis in young people as well. Um, it will get worse with age. Definitely, there's an aging component to arthritis, and again, over 100 different diseases are considered a part of the arthritis family, if you will. Arthritis will strike women more than men, and those numbers are skewed because there's a greater number of autoimmune conditions in women. Things like lupus, fibromyalgia are also cause issues with joints and are part of the arthritis umbrella. How to reduce arthritic changes in our body? Well, number one, maintain a healthy weight. Don't put as much stress on the joints. Limit your inflammatory foods. Inflammatory processes are part of the arthritic changes. Increase your healthy fats. So, lubricating, think olive oil, think omega 3 rich foods. Eat a diet full of antioxidants. Remember, we talked about ROS, reactive oxygen species, and that fruits and vegetables are full of antioxidants. Well, those oxidants are also causing damage to our joints. So, keeping lots of antioxidants in our diet. Controlling your blood sugar. There's evidence that high blood sugar in diabetics and others actually leads to changes in the joints. Keep your body well hydrated. Again, your synovial joints are full of fluid, so if your joints are, quote, dry, then you're going to have more drier joints, and that's going to lead to arthritic changes. And then stay active, but make sure that when you are staying active, that you are using proper body mechanics, that you are warming up sufficiently, and that you're minimizing repetitive movements. Now, that's hard if you are a cyclist or a runner or a tennis player or so many different sports that have repetitive movements over and over and over and over. Those repetitive changes do lead to arthritic changes with time. So let's just name a couple of different types of arthritis. The most common type is osteoarthritis. I already mentioned it, showed you pictures of it. This is simply the aging form of degenerative disease where the cartilage, typically the hyaline cartilage, begins to break down. Rheumatoid arthritis, an autoimmune disease. The lining becomes inflamed. The body's immune system itself is actually attacking it. And again, more common in women. Gout is actually a metabolic disorder with too much uric acid crystals in the joint spaces. Don't worry about that detail, but this is a painful condition. Amazingly, it only attaches or affects smaller joints, the big toe being the most common, and this one is far more common in men, and typically dietary changes and medications are necessary to reduce that form of arthritis. Ankylosing spondylitis is a type of arthritis that affects the spine. There's a nice video of this in the chapter. This is arthritic changes to the vertebra. Lots of spiny growths from the vertebra, very painful condition of the back. Lupus, or SLE, systemic lupus erythematosus. This is a disease. It's a connective tissue autoimmune disease where the joints are also damaged. You may have heard of scleroderma. Scleroderma is a disease that attacks the connective tissues, also leads to a thickening and inflammatory response of the joints. And fibromyalgia also affects the muscles, but also the joints. And we see lupus, scleroderma, and fibromyalgia also more common in women. So again, women unfortunately bear a greater percentage of individuals with arthritic changes. All arthritises are due to some sort of degenerative wear and tear breakdown or an autoimmune inflammatory breakdown of the joints or the tissues around it that affect the joints as well. Already talked to you about this briefly, and that is this is a human embryo from week 5, 6, 7, 8, 9, 10. And I mentioned that it's about week 6 where the arm bud begins to extend. We see that extension happening here. Week 6, and the arm is extending. Apoptosis is occurring. The endochondral lengthening of the bone, of the cartilage is occurring, and then eventually becomes bone. So just a quick reminder of that process as we talked about the development of joints. And then lastly, what can go wrong? This will be just a couple of terms, but as we think about that apoptosis event, whereby the bones are undergoing apoptosis and the fingers are being formed, Well, what can go wrong during those weeks 5 to 10? And here are some examples: polydactyly, ectrodactyly, and syndactyly. You know from your vocab that dactyl means fingers, digits, or toes, poly meaning many. So a person could be born with more than the normal number of 5 digits. We see that up here in this top picture. Ectrodactyly, a lack of digits, most significant and most debilitating on the bottom. We see these claw hands where the fingers have not formed, and we basically just have 2 digits of functional digits. And then syndactyly, where the digits grow together, or webbed fingers. We can see that here in this picture where the third and fourth digits are linked together. And we can see that here also in the toe, where there's both an example of polydactyly, but also syndactyly between that fifth and that also that extra 6-digit toe. So what didn't go right, right? Something did not go right with apoptosis, with the normal breakdown and death of the cells or the bony structures that are related to the formation. And to tell you that story, I'm going to show you this little baby here and tell you a little historical story about a drug called thalidomide. Thalidomide was a drug given to pregnant women to curb their nausea. It was very commonly given in the 50s and 60s. And this drug was somewhat effective in curbing nausea. And if you know about pregnant women, you know that the nausea typically is most significant between the 6th and the 12th week of pregnancy. Well, what did we just say is happening during the 6th and 12th week of pregnancy, right? This is when the arms and the fingers and the limbs are being formed. So, what's the deal here? What was not appreciated when they gave this drug for nausea? And they tested this drug. Thalidomide was tested on animals before it was approved for human use. And turns out, for whatever reason, thalidomide did not affect the limbs of rabbits and mice that they tested the drug on. But babies were being born to women who had been given thalidomide with this condition of phocoamelia. And phocoamelia is just a term meaning a short flipper-like limb. So you can see that the legs and arms did not extend or grow properly, and you also see issues here in the formation of the digits in this little gal. So the this birth defect, there's a whole bunch of people, right, who were born in the late 50s and early 60s who have phocoamelia of affecting all or some of their limbs. And amelia, just so you understand the term, amelia is a term that means a loss of limb. So phocoamelia is just more of a localized flipper-like limb. I remember this term amelia because I remember Amelia Earhart, right, who dropped out of the sky, and I'm sure she lost a limb when she crashed. So that's a horrible way to remember that term. But Amelia definitely lost a limb when she had her crash. Now, we now know why this happened. The thalidomide, yes, it had an effect on curbing nausea, but we now know that the thalidomide also caused a blockage in blood vessel formation, right? It blocked angiogenesis. It blocked the ability of the limbs to form the blood vessels necessary for the elongation. Now, the thalidomide is no longer given for nausea and is no longer given routinely, but the thalidomide is still used in some chemotherapy cocktails, right? So when a person gets chemotherapy, you know that chemotherapy is given to chase after rapidly growing cells. And you also know that tumors, one of the tricks that tumors must do to survive is to increase their angiogenesis. They must increase their blood supply. Well, thalidomide can be added to a chemotherapy cocktail to minimize the formation of new blood vessels so that the tumor is not as successful in getting developed. So thalidomide no longer used for pregnant women and nausea, but is still used in some chemo cocktails. Again, it makes sense. And if you think back to this picture, if you were pregnant and you were taking thalidomide and you blocked the vascularization of the limb structures as they were forming, you would not create, right? The limbs were blocked because of a blocking in angiogenesis. Angiogenesis is a vessel formation. Another way of saying that would be to block neovascularization, the new vascularization, right? The new formation of blood vessels necessary for cancers to be successful. And lastly, what's going to happen to our skeletal system as well as our joints as we get older? We get to look forward to things like osteopenia. Penia is a deficiency in. So osteopenia is a global term, meaning that our bones will get thinner and weaker. And one of the examples of osteopenia is osteoporosis. We're going to see changes specifically to our vertebra, right? We're all going to get a little bit shorter because the space between our vertebra, the intervertebral space, that fibrocartilage, is going to get thinner. Think about it. You've got 24 of those discs along your vertebral column. And if each one of those shrinks just a small amount, 24 times a small amount is a pretty significant change. So if each of those is losing a little bit of depth, then a person shrinks as they get older. Also, the gomphoses, the periodontal ligaments in between the teeth and the jaw bones, also become weaker. That's going to lose teeth, and we're going to also become a little more fragile, so we're more susceptible to fracture when we fall. Again, we're going to see the deterioration of our articulating surfaces leading to arthritis, and these changes are going to begin in childhood and continue throughout our life. And the one thing that a woman can do, or anyone can do, to help their skeleton be as strong as possible as we age is to begin older age with a very strong skeleton. Calcium loss begins to be a very significant issue for women starting around age 35. That is when perimenopausal changes start. And we also see calcium loss in our bones starting around age 45 for men. And while we can't completely stop that loss of calcium and the loss of strength of our bones, we can go into our older ages with as strong a skeleton as possible. And then also exercise helps to maintain our bone density. So starting off with a strong skeleton, going into middle and older age with a stronger skeleton means that we'll have a stronger skeleton for longer as it begins to decline, and continuing to do weightlifting and minimizing those repetitive motions. Make sure you're stretching. Those yoga, tai chi sort of things are also going to help with maintaining your bones, your muscles, your flexibility, and your joint structures.